Okay. Starting. Morning, everyone. I'll be talking about rheumatoid arthritis in this class. So, it is the second most common inflammatory arthritis, the most common, almost affecting most commonly middle-aged females or older females. So, 0.5 to 1% of the adult population are usually affected with rheumatoid arthritis. Most commonly affected age will be 25 to 55 years. Females are more prone for males. The most common region is due to this increase in the estrogens. Then the genes, genotypes, HLA-DRB1 is a gene which is most commonly responsible for that. Usually, rheumatoid arthritis people they'll be positive for that gene. So they share a AA sequence at position 70 to 74 in the third hypervariable regions of HLA-DR beta chain, and they're more prominently associated with production of anti-CCP antibodies. So there's a test known as anti-CCP. So mostly they test positive for that anti-CCP. The highest risk is for the allele 0401. Okay, so most common is the antibody which is positive is anti-CCP. So those are the MHC genes. Coming to the non-MHC genes, you have PTPN22, STAT4, PDI4, TNFA, P3, TREFI, ATLEF4. Just remember the names. So coming to the pathogenesis, so most common it is, you all know it's an autoimmune disorder. So you have genetic factors, you have the environmental factors, then you have antigen presenting cells. The most common cells which are responsible for rheumatoid arthritis is the T cell. You have Th cells and Th1 and Th17. So these are responsible for production of interleukins. So Th17 is responsible for interleukins 17A, 12F, TNF alpha, IL-6, whereas Th1 is responsible for the production of interferon alpha, TNF beta, lymphotoxins. So these will lead to inflammatory reaction, leading to production of a synovium around the joints and thickened synovium, and that leads to increase in the accumulation of all the inflammatory cells, including macrophages and all that. So that leads to production of different reactions. Okay, so that's why you have all these drugs. So like TNF alpha beta blockers. So that's why those drugs are effective in rheumatoid arthritis. So most likely it's an inflammatory reaction leading to the production of all the inflammatory cells. So these two cells are more important, responsible for the reaction Th1 and Th17. Okay. So what's tannus? It is a chronic inflammation, leads to synovial lining hyperplasia. So you have the joints, the synovium joint that will lead to hyperplasia, increase in the layer of the cells, and also thickened cellular membranes, T cells. So all these will be accumulated around the joint, around the synovium. So fibroblasts like synoviocytes and fibrovascular tissue, all these invades the underlying cartilage and bone. So pannus, you have type A and type B. So type A sinusoids are mainly macrophage derived, whereas type B sinusoids is mainly fibroblast derived. So these one you called as type B is you called as pannus. Okay. So it is always pannus is fibroblast derived and it is type B sinusoids. Okay. So mainly the presentation, they have early morning stiffness for more than 1 hour. The patient will come to OPD saying, I have this tightness I feel in the early morning. I feel my hands are very tight and I'm not able to do work, and if I do some activity, I'll be fine. So that's most common presentation of rheumatoid arthritis, early morning stiffness greater than 1 hour, which eases with physical activity. So it can be monoarticular, just one joint, or it can be oligo. Oligo is 4 joints. If it is more than 5, you call it polyarticular. Okay. So most common it will be polyarticular. They say all the small joints like all the hands, they may tell, and even the toe also. So it is usually insidious and additive. Initially 1 joint, 2 joint, and it will progress to many joints. And most common is small joints. It never involves the large joint, like knee joint. It doesn't involve shoulder. So all these are not involved. Only the small joints are most commonly involved. So DIP is very rare. Okay, distal interphalangeal joint phalanges are more rarely involved. Cervical spine is also rarely involved, and on that atlantoaxial is less than 10%. So these are common deformities. So you have this ulnar deviation at the metacarpophalangeal joints. This is also very common. The patient present like that, ulnar deviation, radial deviation at the wrist. So this is how a patient will present. If you see any of these deformity, you can suspect rheumatoid arthritis. Radioulnar subluxation, so volar subluxation at the wrist. So these are most common abnormalities. Mallet fingers, swan neck deformities. That's how it is. Okay, Bottineau defect, Bottineau defect, and Heberden's node, Bouchard's node. These are more commonly seen. Distal end is known as Heberden's node. Distal phalangeal involvement is known as Heberden's. Proximal is Bouchard's. This is a common MCQ question they ask. So this is a Bottineau defect, swan neck and Bottineau, wherein Bottineau defect the PIP joint to become flexed. Okay, so proximal will become flexed and DIP joint is gulled up. So there is hyperextension in the DIP joint and PIP joint is flexed. So exactly opposite is swan neck. So in swan neck, PIP joint is extended. This is extended and DIP is flexed. So just remember, okay. So you can remember BP. So P is Bottineau, PIP is flexed, DIP is extended. Exactly opposite in. If you remember this one, that one you can easily remember. Swan neck is DIP is hyperextended, PIP is flexed. Okay. So thumb deformity, you have interphalangeal joint flexion, metacarpophalangeal joint hyperextension, and CMC is flexion. So this is how we present thumb deformity you call. Okay. So then you have piano key styloid, wherein the UCL is damaged. So this is how the piano key you call it as. Okay. So extra-articular manifestations, you have many extra-articular manifestations. Neurological, you have cervical myelopathy, anemia of chronic disease, wherein the patient will have normocytic normochronic anemia. Neutropenia, spleen will be enlarged. Felty syndrome, large granular lymphocytes, leukemia, lymphomas. All these are more commonly involved. GI, you have vasculitis. Vasculitis is also more commonly involved. And skeletal, you have osteoporosis. Endocrine, you have hypoandrogens. Skin, you have rheumatoid nodules, purpura, pyoderma gangrenosum. All these are more commonly involved. Okay, rheumatoid nodules are more commonly seen. Pyoderma gangrenosum is an acute condition wherein the patient will have acute allergic dermatitis and all. Oral, you may have xerostomia, periodontitis. Ocular, you have scleritis, episcleritis, keratoconjunctivitis, Sicca. So all these are more commonly. Endocrine hypoandrogen is also very commonly seen. Cardiac, you may have pericarditis, ISG, ischemic heart disease, myocarditis, cardiomyopathies, arrhythmias. So most common, there are patients where you see sudden deaths in patients with rheumatoid arthritis. The most common cause of sudden deaths is arrhythmias. Okay. Renal, you have membranous nephropathy. So that's a more commonly seen glomerulonephritis, membranous nephropathy. So coming to rheumatoid nodules, these are subcutaneous nodules. 30 to 40% of patients will see rheumatoid nodules. So it is subcutaneous, and risk factors are highest levels of disease activity. The disease activity is more. You can see the patients having this rheumatoid nodules. So where do you see? You can only see on a radiological evidence. So on a X-ray, you can see so these are the most common sites you can see on the wrist or just below the phalanges. So they'll have they are positive for rheumatoid factor, and they are firm, they are non-tender, they're never painful, and repeated. What are the areas? Repeated trauma, forearm, sacral region, or Achilles tendons. So these are more commonly seen. Even lungs, pleura, and pericardium, peritoneum also can be seen rheumatoid nodules. So Kaplan syndrome is a triad of rheumatoid arthritis, pulmonary nodulosis, and pneumoconiosis, following mainly silica exposure. So a triad of rheumatoid arthritis, pulmonary nodules, and pneumoconiosis following a silica exposure. So this one you call it as Kaplan syndrome. Okay. So arthritis robustus, it is an older man labor. Inflammatory arthritis involving hand and feet. Patient is blissfully aware, and this is how old man labor usually present with that. Okay. So Offeltis syndrome, it is a late manifestation and is a very rare disorder wherein you see a triad of neutropenia, splenomegaly, and nodular. So this could be your short notes. Offeltis syndrome, 2 markers. So it is a rare manifestation wherein you see neutropenia, splenomegaly, and nodular rheumatoid arthritis. Okay. So then coming to complications, you have infections, cytopenias like pancytopenia, ulcers, and chronic LGL leukemia is very rare condition. Okay, so but complications, infections are more common. Palindromic rheumatism, it is a brief but intense episodes of joint inflammation, wherein it is mostly monoarticular, only single joints may be involved, but it affects large joints. Okay, I've already told rheumatoid arthritis never most rarely affects larger joints, but if it, you call it, the name itself says palindromic rheumatism, so it affects knees, fingers, shoulders, almost all the joints are affected. It mimics crystalline arthropathy or septic arthritis. So how do you diagnose it? Do a rheumatoid RA factor anti-CCP positive, so they can be positive for that. That's how you diagnose it as. So about 1/3 to half of patients evolve to rheumatoid arthritis, hand involvement, and then ACPA positivity. If you see, they'll be positive for RA and ICPA. Others may continue as palindrome or crystal associated arthropathy. So this is the most common criteria which you for diagnosing of rheumatoid arthritis, known as EULAR or ACR criteria. So it is European League as Rheumatism or American College of Rheumatology criteria. So it was first coined in 2010. So this criteria, you have four parameters. One is joints affected, number of joints affected. Second one is serology. Third one is the duration of the symptoms, and the fourth one is acute phase reactance. Okay. So coming to the joints affected, if the joints number of joints affected are only 1, the score will be 0. If there is 2 to 10 large joints, score will be 1. 1 to 3 small joints, score will be 2, and 4 to 10, score will be 5. So that's how it is. So if there are 4 to 10 small joints affected, the score will be 5 here. Okay. And coming to serology, if it is negative and both RF and anti-CCP negative, score is 0. Low positive rheumatoid factor or ACPA, score is 2. And if it is high positive RF factor or anti both, and score will be 3. Duration of symptoms, if the duration is less than 6 weeks, 0, is greater than 6 weeks, 1. Acute phase reactance, normal CRP and ESR, score is 0. Abnormal CRP or ESR, score is 1. Okay, so the acute phase reactance, you have 0 and 1 score. Okay, so this is how now you call it as definite rheumatoid arthritis if score is greater than or equal to 6. Okay, let's say if the 4 to 10 small joint, almost score is 5 here only, and if along with either positive RA or rheumatoid ACPA, the score is absolutely greater than 6, so it is definite rheumatoid arthritis. So just remember this table is very important. So the parameters here are involved are joints affected, number of joints affected, the serology, rheumatoid factor and anti-CCP, duration of symptoms, and acute phase reactance, mainly CRP and ESR. Okay. So rheumatoid factor positivity, most common is IgM type. IgG, IgA isotopes can also be seen, but most common is IgM. Other conditions where RF is positive is, so it has many false positives. So other conditions where it can be positive is Sjögren's syndrome, SLE, type 2 mixed essential cryoglobulinemia, like hepatitis B and hepatitis C infections. So 1 to 5% of healthy populations. So all these are positive, wherein you see positive rheumatoid factors. 30% of patients have with rheumatoid arthritis also have ANA positive. Okay, so ANA is usually positive, you know, in SLE, right? So even if 30% of patients in SLE may come out to be positive in rheumatoid factor RF. Okay, ACPA is more specific. Okay, so that's why you do anti-CCP for all the, if anti-CCP is positive, most likely it is rheumatoid arthritis. Okay, this is more specific. That's why anti-CCP is more specific. So synovial fluid analysis, you'll do a synovial fluid analysis just to rule out if you feel that it is not rheumatoid arthritis, if it is septic arthritis and something else seronegative, then you can go for synovial fluid analysis. Usually it's not done in rheumatoid arthritis. But if you suspect, if the if you say RA is weakly positive and anti-CCP is negative, in that cases you can go for SFA, synovial fluid analysis, wherein the counts will be around 5,000 to 5,000 and 50,000. In between that, there'll be neutrophil predominance. Okay, mucin. So if it is greater than 50,000, then that you call it septic arthritis. Okay, so the neutrophils will be predominant. Mucin clot, which is negative. So mucin clot test is always negative. That is mainly due to the decreased deficiency in hyaluronic acid. Okay. So rhagocytes are very characteristic of rheumatoid arthritis. So rhagocytes, also known as rheumatoid cells or inclusion body cells, okay, mainly due to phagocytosis. So you just remember the name rhagocytes, which are also known as rheumatoid cells or inclusion bodies. So these are mainly due to phagocytosis. Okay. So X-ray, you will see a periarticular osteopenia, and then you have soft tissue swelling, symmetrical joint space loss. The joint space will be lost, and subchondral erosions, mainly MCPs, PIPs, and MTPs. So joint subluxation and collapse also can be seen. Okay, so you see erosions here, completely eroded here. See here, joint is eroded. So it's most likely it is rheumatoid arthritis. So MRI or USG can be done to rule out synovitis, joint effusions, bone marrow edema, or vascularity. Okay. So outcome measures, just remember the names: disease activity score in 28 joints. So you call DAS28. This is more commonly used. Okay. So you can just tell the thresholds of the disease activity. It is if it is high, then it's greater than 5.5. So the other names are simplified disease activity index, clinical disease activity index, rheumatoid arthritis disease activity index, RADA you call it, patient activity scale, and routine assessment patient index scale. So the DAS28 is most commonly done to mainly to tell the patient is outcome, how is outcome. Okay, so how do you calculate the DAS28 score? Because there's only one ask usually in your vivas. So count the number of tender joints. Let's say patient say I have all these joints involved. Just count the number of tender joints. Count the number of swollen joints as well. How many joints are swollen? Measure the ESR. Okay, then ask the patient to rate global activity of arthritis during the last week from, let's say, 0 to 100. So let's say if the patient is severe, they can say 100. This is very mild, you can say 10 or 5, like that. Okay, then you have a calculator, then you calculate the score. 0.56 into square root of tender joints plus 0.28 into square root of swollen joints plus 0.70. So this is mainly done by calculator. So that's how you do a DAS28 score. Rheumatologists usually do this to just tell them the outcome of the rheumatoid arthritis. So coming to the management part, the most common initial management is usually NSAIDs. NSAIDs, you have analgesics, you have COX-2 and COX like non-competitive inhibitors. So COX-2 are more commonly preferred because they can prevent the gastritis. So then you have anti-inflammatory like steroids. Then you have many anti-inflammatory agents, cytotoxic and all. You have organics also, adjuncts. Then steroids, you have acute or chronic. High dose steroids are only reserved for vasculitis, okay, or ILD disease. Intra-articular steroids can be given the patient has any effusion or severe effusion. Patient, you can go for intra-articular steroids. Painful, the patient will come with, I'm not able to move it. No history of trauma. The patient may tell that he has high. We can give intra-articular steroids. Okay. Steroids greater than 5 mg per day, greater than if you have to give steroids for long term, then you go for bisphosphonates, because steroids causes osteoporosis. That's why bisphosphonates have to be given. Okay. So what are the DMARDs which are used for the treatment? Disease modifying anti-rheumatoid drugs. Okay. So these are the hydroxychloroquine more commonly used, HCQs. Dosage is around 200 to 400 milligrams per day oral. So toxicities, HCQ is hydrotoxic, is cardiotoxic, and also retinal damage can be seen in blood cytopenia also. So then nausea, diarrhea, headache also can be seen. So initially before starting HCQ, you have to make sure there is no retinal damage, and then fundoscopy should be done every 12 months. Then coming to sulfasalazine, initially you start with 500 mg orally twice daily. Maintenance is around 1000 to 1500. Rarely used. Sulfasalazine is not used routinely used. It causes G6PD deficiencies. Because it causes G6PD, you have to look for CBC and LFT also, G6PD levels also. Methotrexate also can be used. Methotrexate, so dose will be to 10 to 25 mg per week. Weekly dose 10 to 25 mg, but along, because it's a folic acid antagonist, the mechanism of action is folic acid antagonist, you have to give folic acid supplements along with that to reduce the toxicity. Okay, but the most side effect is hepatotoxic, even renal toxic, and the pregnancy catex drug never indicated in pregnant patients. Okay, then you do CBC, LFTs, and viral hepatitis panel. So do before starting on methotrexate. Then coming to leflunomide, if the patient is not tolerable to methotrexate, you can give leflunomide. This is also very rarely used. More commonly used HCQs and methotrexate and steroids. 10 to 20 mg per day. This is also hepatotoxic and also pregnancy catex drug. So it can cause alopecia and diarrhea. Okay. Then you come into organic drugs. You have OMABs, mainly derived from mouse. Chimeric, Zmab, humanized, Zumab, and it is mainly human. It is UMAB. So just remember, if it is Zmab, then it is the chimeric derived. Mouse, OMAB, O mouse. Okay. Humanized, Zumab. Human completely, UMAB. Okay. So anti-TNF, I already told TNF is more commonly responsible for rheumatoid arthritis. You block that. So anti-TNF. So you have this etanercept, TNF soluble decoy receptor. So route is subcutaneous. You give subcutaneous injections, 50 mg weekly. Okay. So infliximab. So it is a monoclonal antibody given IV, 2 to 5 mg per kg. So frequency is at the start dose, second week and sixth week. So MUMAB, so I will tell UMAB is human. Okay, all these three are humans. So the Zmab is chimeric derived. Okay, that's how you remember the names. So adalimumab is it is also subcutaneous. All these three are subcutaneous. Dosage, you can, it's okay if you don't remember the dosage, but just remember the names. Names are very, if you write the names, that's enough. Anti-NF, etanercept, infliximab, adalimumab, golimumab, and certolizumab. This is PEG anti-TNF monoclonal, recent one. This is more commonly used. Okay. So what are the side effects of all these organics? Acute infections. So like tuberculosis, more commonly seen. Okay. Stopping therapy because of an adverse. That's how you stop it. Okay. So you have injection reactions, drug-related lupus reaction also seen. Serious infections. Tuberculosis, non-Hodgkin lymphoma are more commonly seen. So what are the contraindications? Class 3 or 4 heart failure, demyelinating diseases, malignancies, active tuberculosis. All these are contraindications for starting monoclonal antibodies. Okay, active TB or recent infections. So commonly used biologics, I've already told, these anti-TNF ones or can be used. Anti-B cell therapies, you have rituximab. These are very expensive drugs, so it should be reserved, only some particular people who are affordable and wherein you see or don't see any of these complicated. The patient doesn't have an infection or TB, you can start with it. So anti-IL-6 we have tocilizumab, anti-IL-1 you have anakinra. Okay, so remember this. So abatacept is T cell activation inhibition, anti-IL-6 is tocilizumab, anti-IL-1 is anakinra, anti-B cell is rituximab, and then you have anti-TNF alpha, you have all these. All right, so this is how you remember the names. See, this chart will help you. Yeah, abatacept is anti-TCL. Okay, so tocilizumab IL-6 inhibitor. Okay, it will inhibit IL-6. So TNF alpha, all these TNF alpha drugs, anti-TNF. Rituximab B cell inhibitor. Okay, so that's why it will inhibit all these cells. These cells are responsible for the reaction. that will inhibit. So T cell is okay. So ACR ULR definition remission. So at any point, patient must satisfy all the following: like tender joint should be less than 1, swelling joint should be less than 1, CRP less than 1 mg, patient global assessment less than 1. Okay, so this is how you can tell that patient is recovering or improving better. Okay, thank you.